very fascinating case which has got a very much relevance in clinical practice, because generally what we say is that we often will talk about physiology and pathology, and often certain scenarios in pediatric endocrinology will be such which will be a marker of a serious disease which may often be missed with disastrous consequences. So we'll talk about a common presentation with an uncommon cause in which there were a lot of issues. It's part of our Grand On series which we do every month, and you all can have a look at our website learning.rosociety.in, which has got a lot of information about pediatric endocrinology. We've got various courses which are available, including a comprehensive fellowship and a diploma course. There are a lot of programs going on in terms of the journal clubs, in terms of the lecture series that we have, and the publications and mobile applications which are available. So today we're going to focus about a very interesting case of a delayed puberty, which really emphasizes how a common condition, a pediatric endocrine condition, can have huge implications in terms of the outcome.
Yes, sir. Good afternoon, everybody. So we recently had a 16-year-old girl in the office who had visited a pediatrician for complaints of delayed puberty. She also had all of mild to moderate executive worry, but she had no vomiting, no visual symptoms, and no incontinence. On examination, her weight and height was appropriate for age. The SMR was B2B1. Initial workup.
So just hold on from there. So now, if you talk about a 16-year-old girl who has come to you with delayed puberty, what are the key 1, 2, 3 possibilities you will think? What is the most likely cause in this scenario?
Delayed puberty is rare in girls. In boys, it may be physiological, but delayed puberty is just rare in girls. So we will like to think of in lines of.
So, if you forget about this particular age or other demographics, if I just say, what about delayed puberty in girls? What are the various proportion of cases you will think of in terms of etiology? So how many cases you think? How percentage wise? So 35 to 40% will actually be CDGP. Then you will have a group like 20%, 30% will actually be something like Turner syndrome. So hypergonadotropic hypogonadism. Then 15-20% will be systemic illness, and 15% roughly will be hypergonadotropic hypogonadism. So still the leading cause will be CDGP. In boys, the chance will be double. So it will be like 60-70%. Now, what I'm trying to say is that what are the pointers? So when you are evaluating such a child, you want to know when I am not dealing with CDGP. So what will be the pointers that will point, okay, this girl doesn't look like CDGP.
So your growth was appropriate for it. So her height and weight were not
yes.
compromised.
So her height was normal for age. Second scenario that you were saying is that the age is a bit more. So 16 years in girls is pretty advanced. So it will be a bit later presentation. What about what else?
In favor of CDGP.
Again CDGP.
Again CDGP is again headache.
So headache is a phenomenon which we will ask about. The breast development, generally they don't have any breast development at all. So it may be that she is CDGP and now she is entering puberty. That is why she has breast stage 2 development. But then that is a possibility. So what are favoring CDGP in this scenario?
B2B1 is definitely.
So there is no pubic hair development, which is also effective. So that will be the thing that you have to worry about. So this looks, I would be very wary about labeling this girl as CDGP in this scenario because she is reasonably tall. And then you will ask about the specific other complaints. Any family history of delay was not there in this case. So again, these are the red herrings that you're dealing with, something beyond just CDGP. So now when you go beyond CDGP, of course, you are mainly concerned about a lot of hypergonadotropic hypogonadism. So what are the features of hypergonadotropic hypogonadism that you will get on examination or history?
The hypergonadotropic hypogonadism will be terminal will be there. So short stature, anthropometry will be.
So short stature, typical, all the facial features, skeletal features. So that you will be there. So that was obviously not there in this case. This girl was a normal built, normal statured child. So that becomes unlikely. Of course, you can have some other forms of gonadal dysgenesis which may not have that much abnormalities which are there. Do you think this could be a systemic illness scenario, Vibha?
So in the systemic illness, first of all, as she said, the weight was appropriate for that.
So you will expect the height and weight to be affected. The child will be more sick in that scenario. So a non-sick child who is not short always think of something which may be sinister in that perspective. Now, you've got breast stage 2. Will you call it a stalled puberty or will you call it a delayed puberty to begin with? What did the parents tell you?
They said that no development has.
So no development. So maybe it is both ways. There was some initial development and then it stopped. So it's difficult to say, but if you get a clear-cut feature of stalled puberty, then you are really worried about certain causes. So what are the conditions which are excluded by a stalled puberty?
If it was CDGP, it would not have a.
So CDGP will never have a stalled puberty. What else do you think, Manoj, if you have a stalled puberty rather than a complete absence of puberty? So what I'm asking to you is that what are the causes in which there is no development at all?
So congenital hypogonadotrophic hypogonadism is out.
Congenital HH also. Okay, so if there is a, unless you say it's a mildish form in which you can have some development, so there is a spectrum. But the severe forms of MPHDs are typically lost, but they are anyway less likely because of the height and weight. Then you said congenital HH, yes, so plus minus anything else.
Severe form of Turner syndrome.
So Turner syndrome, I would not say anything on that. B2, I wouldn't be worried about. Turner syndrome, pretty much we can have that.
Systemic illness is the.
Not really, because how much it is affected. So I would say the other thing which will be out will be something like aromatase deficiency, estrogen receptor defect, something which are very, very severe, like in which you have zero function. So that will be out in that regard. So definitely you have got some breast development, means that whatever the illness is not completely knocking off the system. There is some scope of growth there. The other big thing is that if it is stalled puberty, the first thing I will think about is the acquired lesion that you have to be really bothered about. And as I always say, that although most children with delayed puberty may not have a pathology, it may be a marker of a sinister pathology which happened in this case. Now let's go on to the workup.
So initial screening for systemic illness was in the normal range. PSH was in the normal range and prolactin level was normal. FSH was not high and LH was definitely in the puberty, had come into the pubertal range.
Do we have an estrogen level as well? So what we are seeing here is that there is a decreased amount of LH and FSH, but whether it is really low, it's not in the zero range. So if you talk about Calamin and many of those GnRH receptor defects or the defects of FGF receptor or charge, all those scenarios, the levels are much, much lower. So this maybe somebody might say, okay, this girl has now just entered puberty, LH is slightly high, so let's wait and watch. This could be a problem which may happen in this scenario. Okay, why was a karyotype done? So I think that is another big message, that nobody should do a karyotype unless you have got a documented hypergonadotropic hypogonadism. Unless you have done that, why unnecessarily do karyotype in the beginning in this phase? And this is very common scenario. So this is clearly a hypo scenario.
Somehow for delayed puberty, hypoplastic uterus with non-vagina.
So at least they showed a hypoplastic uterus. Often you will get a report of no uterus. So this is of no concern. So as we say, if there is no breast, no uterus, don't get an ultrasound done also. So that is of no consequence per se. And ovary and all, unless you are doing a transvaginal, it's very, very difficult. So I don't give much importance to a pelvic imaging at this stage. So now if we look at this picture, Manoj, what do you think? Do you think this could be CDGP which is improving? Theoretically, yes.
Yes.
Theoretically,
LH-FSH is not that much low. So
yeah, so now it's picking up. B2 has also happened. So this can be a tricky scenario in which you can say, okay, let's wait and watch. This could be a general sort of a dictum. However, the finding of headache. So did you get the headache primary on, were they having this complaint of headache, or was it a retrospective finding?
It was definitely a retrospective finding. It was something that we found on probing whether she had. So she said yes or no, she had.
So that's a difficult scenario. But I think this brings us to a very, very important thing, that if somebody is 16 years, so that's what we have to think in a holistic picture. Otherwise, if you look at it, any approach, it will say, okay, this is like a CDGP / a hypo. But neurological features, so they have to be very cautious about etiology of neurological features, which will be there. So now the big question is, would you do MRI in this girl?
So definitely, she has she is presenting with a headache, and if she has other neurological, we should go for them.
Yes, so it's a difficult scenario. In a busy practice, you may say, okay, this is CDGP, let's wait. But the message is that if somebody is 16 years and still no development is not there, LH is just marginally elevated, think about a evaluation further. You carry forward.
So it's the same thing. If you go by the application, by definition, this girl definitely fits into the criteria where you would want to evaluate her for delayed puberty. The initial screening was normal, FSH was not high, so here we're not thinking of Turner syndrome. Prolactin was in the normal range, and she had headache. So if you go by this, the app gives us an interpretation that this may be a permanent HH. Go for an MRI.
But if we do not go into that history, it will probably say that this will be a scenario in which it will go more towards LH level. And if your LH is like 0.4 or something, it may say CDGP. So that brings a very, very important pointer that you have to think of neurological features. That is the major message, I think, in the beginning of this case. Yeah. So carry forward.
The lesion was hyperintense for T2 imaging with focal areas of T2 hyperintensity instead of calcification. It was anteriorly abutting the optic chiasma and posteriorly abutting the interpedunculaar system. The pituitary gland was separately visualized with the above described lesion. So the treating pediatrician went ahead with an ophthalmic.
So now, if you look at this sort of a picture, I know this is very, very characteristic, but often there is confusion, as we always say, supracellular lesion, which is coming from above and coming down, and a cellular lesion, which is going up. Now, what are the key pointers that this suggests that this is a purely non-cellular lesion, clinically, investigation-wise, and this imaging?
So, cellular lesion, they will usually also have a supracellular lesion may have hyperlactin levels. When it descends down, it may cause anterior pituitary function defects, and in cellular, they may be present upfront. So the endocrine deficiencies may be present upfront.
So the chances of having endocrine deficiencies will be lower in somebody who has a supracellular mass to begin with. Deficiencies will happen when you have surgical intervention, which is done. Similarly, the other thing is that that your prolactin, as you said, if prolactin was high, it will more suggest towards a stalk compression. The LH-FSH levels, what do you think? So both scenario, if it is causing obstruction, they will be low. But one important pointer on imaging is suggesting that this is purely a supracellular lesion.
So a figure of 8 appearance.
Anything else which is there in this MRI that you have mentioned? Pituitary is separate. So if normally we say, even if you see a rim of pituitary around the lesion, that itself is a separate thing. But here it is classically, this is not there. So now if we talk about a girl who is 16 years old, who definitely has had this lesion, not now, for quite some time. This has to be there because though puberty has happened maybe few years, a large lesion with this sort of a pattern with calcification, I think there is no differential in terms of that. So this will be a craniopharyngioma, which is classically there in that. Yeah. Carry forward.
She was shown to an ophthalmic specialty down here. So like Sir has said that a 16-year-old girl presenting with delayed puberty who has a pre-puberty development on examination with a normal height, normal vision examination. With this classical MRI image, there is no other differential that comes to my mind like that.
Post-operative complication and perioperative complication of the craniopharyngioma. So, as I want to repeat the third sentence, it is a benign malignant tumor. That means it is a benign because it don't metastasize, but because of its prime location, it is, and because of the lot of the complication that it left after the surgery, it makes us malignant. So, all the complication occur after the sequelae of the surgery. So here there are so many surgeries that we have previously discussed. Most the complication occur with every surgery. So there are a lot of the complication that occur. So we have to divide into the main 4 category where visual complication is there, followed by neuroendocrine and hypothalamic dysfunction. And in the long term, they behave with the neurological and neuropsychological complication, which makes life is very complicated because the health-related issue, behavior issues, school problem, and then sometimes they lost control on their anger. So among these all complications, MPHD, multiple pituitary hormone deficiency, is acceptable, but hypothalamic function is not acceptable because it is very difficult to treat. In the case of the MPHD, we replace the dose and we can treat this patient. But in case of the hypothalamic complication, it is very hard to treat, and there are no such pharmacological treatment is available. So what should be the goal after the post-surgical management? So first goal should be the focus on the identification of the recurrence or the progression. Second, if the hormonal deficiency is there, then we have to adequately replace the hormonal therapy with the treatment of the seizures. Third, prevention and therapy of the long-term side effects. And we have to treat the hypothalamic dysfunction. We have to identify weight gain and obesity, and we have to treat accordingly. And five, the improvement of the quality of the life with a disciplinary team with the psychiatric, psychologists, and the physical educators. So, now previously we have talked about there are two modes of the therapy. So one therapy is a gross total resection. Second is a conventional surgery followed by the radiotherapy. So we have discussed both the therapy where the gross resection is now become very less common, and it only occur in it should be done only in case of the small tumor. And where there are the high rates of the hypothalamic obesity and pan-hypopituitarism after that, but recurrence rate are very low. But if we talk about the conservative surgery and the radiotherapy, then recurrence rate are very less, but they bring so many complications like radiotherapy induced secondary tumor, and again surgery they have to do. So adhesion is there, and there are a lot of hypothalamic complications they bring. So now, the newer therapy has came like a cyber knife and all. So it brings very less complication in all according to the way case series. So here I am according to one case series, they have shown less recurrence after the 25 months of the post-surgical time. So what are the endocrine issues that we are generally facing? So DI is very most common presentation post-operatively, and there are the decrease in the dose of the desmopressin in form of the cortisol deficiency. So if patient is feeling lethargy and weakness, and there are the typical dose reduction in case of the AVP requirement. So that time we have to think about the cortisol deficiency. Second thing, inadequate cortisol level in term with the hypoglycemia and hyponatremia. And ACTH stimulation test is a diagnostic of the secondary adrenal insufficiency. Here, normal cortisol level can false negative in terms of the adrenal insufficiency. So if normal cortisol level is there, then we have to, and the symptoms is there, then we have to do ACTH stimulation test. Second, anti-epileptic, because they are more prone for the seizure. So anti-epileptic also induce the metabolism high zone. So in this case, we have to increase the dose of Hyzon. After that, we have to give TSH thyroxine supplements if the central hypothyroidism is there. Here, TSH strategy should be not followed. We have to follow for the diagnosis of the pre-T4 for the diagnosis and the management perspective. And here we have to identify by the growth chart if it is deviating more than the 2 line. Then then growth hormone stimulation test should be done. There are no role of the basal growth hormone, and in some case, in the initial first to 2 year, growth occur without the growth hormone because of the high IGF level in this case. So because of the obesity, it caused the growth.
So this is important that anyway in the first year we say you don't give growth hormone because of the risk of recurrence and increased size is there. But growth failure usually happens by 2 to 3 years. As you said, initial endocrine manifestation will be DI, which is maybe immediate. Cortisol also may happen pretty quickly, but then obesity becomes a big problem. We all know that obesity causes insulin resistance, high levels of free IGF-1, low IGF-BP, all that thing causes normal growth. So usually they will not deviate, but ultimately delayed puberty and growth failure become universal towards the end.
And here, growth hormone supplement should be at the last, because suppose in patient, if growth hormone deficiency is there, and so it can induce the adrenal insufficiency. So here, after the growth hormone supplements, there can be chances of the increased dose requirement. And sex steroid replacement should be done at the last, and it should be the gradual if the primary amenorrhea is there, and sometimes it present with the precocious puberty. So in this case, we have to treat it accordingly.
After surgery, this precocious puberty will go off anyway. So you don't need to generally, because that then your hypothalamus is already gone. So it's usually, so this will be less of a problem. But definitely delayed puberty, like in this girl, what do you expect in terms of hormonal abnormalities?
In our girl.
Yeah.
So
this sort of an approach which has been done. So what will be the chances of her having an MPH?
So in this girl, chances of the even because gross total resection is there, so there are the high chances of the pan-hypopituitarism, but there are the less chances of the hypothalamic involvement.
Yes. So already what we are seeing is that she already had a problem in the pubertal development. So she already had pretty much many abnormalities happening. And if you have removed this big tumor, you will expect a cortisol deficiency. Growth hormone also you will expect subsequently. DI will be plus minus. But as you said, since it's not very close to the vital structures, it may cause less involvement of the other severe symptoms. Like, so what are the classical hypothalamic symptoms?
So they mainly present with the emotional lability, or the front seizure, or the mainly obesity, and the social issue. Their behavior issue, like they have more anger, more tantrum.
So of course, hyperphagia and obesity may become worsen, cold feeling and cold intolerance, hypothalamic dysfunctions, so
sleep disturbance.
So that is the main sleep, eat, all that area is affected, which will have a dramatic impact. Carry on.
So now, if we talk about the causes of the obesity of the craniopharyngioma surgery, then it is not only due to the hypothalamic dysfunction. Hypothalamic dysfunction causes the satiation issue. And with the adding of the satiation issue, there are the reduced energy expenditure also cause here obesity. And low muscle mass with the more fat due to the hypogonadism, and due to the growth hormone deficiency cause the obesity. And there are the altered sleep pattern and altered circadian rhythm also cause the obesity.
So when you say hypothalamic obesity, what is the main biochemical mechanism of hypothalamic obesity?
Sir, in the hypothalamus, there are the so many anorexic signal is there, which is conducted by the leptin, and leptin act on this receptor, and the GLP-1 analogs also act on this receptor. So
predominantly, it is like a leptin resistance. So this is a leptin resistance. If your leptin levels are not working, what will be the body? What will the body do?
So if leptin is not working, then body says that this fellow will die because of the less energy. So it will try to conserve energy.
So it will first of all increase intake. So it will take more and decrease. So both of that will say reduce energy expenditure, and these are part of the hypothalamic dysfunction, which is there. So definitely this will be important part.
So if they have pre-op or post-op visual field effect in the physical activities restriction.
So of course, that is physical activity, and you just said that growth hormone deficiency, the adipogenic. So they will behave a bit like Prader-Willi. If you think of it basically from a very, I'm not saying it from a classical perspective, but if you look at it, Prader-Willi is the same thing. They have hypothalamic dysfunction, they have cold issues, they have sleep issues, they have behavioral issues. They will have hyperphagia, they will have partial growth hormone deficiency, more adiposity. So craniopharyngioma is like quote unquote acquired Prader-Willi, if you want to say that, or it is a leptin resistant state. That's what the basic you can say on that. Yeah.
So there are so many research has been done for prevention of this craniopharyngioma induced obesity.
And oxytocin, as we discussed last time, is also a treatment for
Prader-Willi. So here, if we treat about what are the strategy that we have to follow to prevent and treat the hypothalamic obesity. So first, in this case, obesity is there. So it causes the insulin resistance. High insulin can blunt the effect of the satiation. So here we have to decrease the insulin secretion. So we have to administrate that molecule which act with decrease the insulin secretion like diazoxide, and the metformin which cause the insulin sensitivity. So diazoxide and metformin is also can be used, and yes, we can reduce the lipid level. So fenofibrate with the in the background of the metformin we can use. GNP1 analogs can induce the satiety. So in this case, it can be treatment of choice in
But
case.
if there is no hypothalamus in liver.
But sir, it means it decrease the intake and it increase the insulin sensitivity.
You will indicate food satiety center only. So if the center is gone, will it work?
Sir, no, it will not work. So according to literature, it is not. This is the strategy that we can
So
think.
this is the theoretical thing you can think of, but you also have to think of what can really work out from that perspective. So if you talk about diazoxide, so when you are going to use diazoxide, what could be the problem?
With diazoxide.
In an obese child, if you use diazoxide,
Hyperuricemia, edema, diabetes.
you will cause diabetes.
Yes.
So you have to be very, very cautious in terms of that. So it's just theoretically they have mentioned it, but you need to understand when you are using diazoxide, you are actually causing insulopenia. If somebody who is already, his sugars are being controlled because of that high insulin. So you have to think this is a compensatory response. If I take out that compensation, he'll go into diabetes. So diazoxide would not be, so none of them I think would be the clinically used. This is more like theoretical. Metformin, of course, there is no conclusion that if you have insulin resistance, you improve that. What is the effect of insulin resistance on obesity?
Insulin.
Does insulin resistance have an effect? Is obesity causes insulin resistance? But does insulin resistance also cause something on the fat?
Insulin resistance.
It is a like vicious cycle. Increase insulin has a.
So insulin actually acts on the central areas and causes all the same things. Like insulin is a marker of nutrition abundance. So if you remember when we talked about the monogenic obesity, we say that insulin is also a peripheral signal that this insulin will go to the brain and say, okay, don't eat and do more energy. Let's go to catabolism. So if you have insulin resistance, also the problem will be there. So metformin will definitely be able to help you out. So now this is there. So they have also mentioned T3. So nobody will think of T3 as a perspective unless there is a hypothyroidism. Yeah. So
we can act on the MC. We can give the medicine which work on the MC4 receptor agonist, which is the setmelanotide, but it is very expensive and there is no further studies available.
No, so basically, you need to understand the theoretical possibilities. But the main problem here is that the whole central processing unit, you don't know how much is gone. So if it is gone, then probably there is nothing much you can do. So that is the whole point. So the management of hypothalamic obesity is very, very challenging. It's not going to be easy. You can think of insulin sensitizers. Now, what we are trying to say that, okay, some part of the brain is working. So there we are using GLP-1 receptor analog. GLP-1 receptor analog will cause decreased gastric emptying, so the abdomen will become full. So all those things. But otherwise, management is a bit less and difficult on that, challenging. Any role of octreotide?
Sir, octreotide, it is like diazoxide only. So there are no.
Octreotide not from that perspective. Somatostatin.
So much, sir, no improvement has been seen.
So that is what has been studied in hypothalamic obesity as an agent. Octreotide definitely has been studied as an agent. Okay, carry forward.
And they have tried by giving a central stimulant like dextroamphetamine and ephedrine, but there was no success has been found. And finally, they have tried with the oxytocin with the combination of the naltrexone, and this combination has a successful result in terms of the reduction of the BMI, while other parameters have not seen that much result in case of the reduced BMI, but more side effect is there rather than the benefits.
So if you now put it in that perspective, it is more like treating a Prader-Willi patient. If the patient has got growth hormone deficiency or growth failure, you definitely give growth hormone. It is not only going to improve the growth, but also in terms of muscle mass, in terms of fat mass will become less, and there will be other benefits in composition. Now, oxytocin, again, we have not used it, but this is something which may be an interesting way to go forward. Now, what does the other opioid blockers, what do they do basically? Is that they will body will have a feeling that they are happy.
They are happy.
So they will not need that in that regard. So often it becomes like a addiction. Obviously, the hyperphagia becomes an addiction that will be taken care of from them. Yeah.
So according to the literature, what they have studied, they have decreased the insulin resistance and decreased the insulin secretion by the help of the carbohydrate restriction. But it was not helpful because here energy expenditure is also issue. Second thing that they have tried with the diazoxide and metformin combination. So diazoxide and metformin combination have been effective in terms of the reduction of the BMI. But there are so many complications because of the hyperuricemia, edema, diabetic development. Here is, if we see in conclusion, that 2 months after treatment, there are some patients that who developed the diabetes among 40 patient study, and there are so many side effects in terms of the treatment.
Not theoretically also not of much sense.
So the other therapy they have tried with the fenofibrate, but it don't reduce the obesity, but it can be helpful when the dyslipidemia is there. It improves the dyslipidemia and it can decrease the insulin. It can increase the insulin sensitivity. And while if we are talking about the CNS stimulator like amphetamine and other agent like caffeine and all, they have more side effect like a cardiovascular mortality and cardiovascular complication in terms of the reduction of the BMI. So these agents are also not useful. And the role of the oxytocin and naltrexone they have tried, it has received a successful outcome. So if we combine all these agents, then central stimulant has a greater side effect. It reduce the
ban. So most people will not be using that. So those agents will anyway be centrally acting agents, they will not be considering. But yes, definitely orthotide was something which was often used earlier. The other agent, of course, as I said, metformin will be the good agent, and maybe a role of oxytocin will be a one.
So they have tried with the octreotide in the 30 pediatric craniopharyngioma patient, but they haven't seen any beneficial role for the reduction of the obesity. So there was no any BMI reduction. So if we talk about the if we compare about the diazoxide alone and the combination with the metformin, then diazoxide and metformin has a reduction of the weight gain, but in terms of the more side effect, and the fenofibrate and metformin have no any significant result. So if we talk about the GLP-1 analogs, then they haven't found any significant result because it improves the cardiovascular profile or dyslipidemia, but it don't reduce the BMI except one case series which has conducted in adult. So finally, oxytocin and naltrexone have benefits. And if we talk about the growth hormone supplements to reduce the obesity while we are using in the Prader-Willi syndrome, but growth hormone supplements here also don't reduce the BMI in this hypothalamic obesity. So if hypothalamic obesity is not preventable with this pharmacological agent, then definitely we have to go for the bariatric surgery. But again, bariatric surgery in the pediatric population has a very limited recommendation. So there are the 3 types of the gastric surgery: gastric mending, Roux-en-Y bypass, and the sleeve gastrostomy. But there are the less chances of the weight reduction with the gastric mending. And Roux-en-Y has a lots many complications like malabsorption, dumping syndrome, and electrolyte imbalance. They children are more prone for the seizure already, and because of the electrolyte imbalance, they have more seizure. So it has not a good outcome. And according to study, weight loss is relatively short-lived in this patient. And after the long-term treatment, they come to the pre-treatment pre-surgery weight gain after the long-term follow-up. So here also bariatric surgery is not a very good option for the prevention of the obesity. And if we talk about the sleep disturbance, then sleep.
So, the other thing to look at the frankly, we have not seen that level of obesity in most patients, the craniopharyngioma survivors, which may be because of the type of lesion, the severity of lesion. So we haven't seen anybody who has become massively obese, and this girl also was pretty normal from that.
And the second issue is a sleep disturbance, which occurred due to the decrease the cortisol secretion and decrease the melatonin secretion. So it caused the it increases the obesity. Sleep fragmentation is there, increased daytime sleepiness, and consistent hypersomnia and secondary narcolepsy. So in this case, the melatonin therapy may cause the beneficial role in terms of the in terms of the outcome and reduction of the obesity. So they have after that they gone through the most side effect like the neuropsychiatric and behavior issue, like behavior in emotional problem. They can have a mood swings, decrease school performance, and decrease social functioning, decrease long time survival due to these all complication, and they have a typical memory deficit in terms of the episodic memory deficiency, largely sparing other memory component. And yes, we don't have to forget about the recurrence of the craniopharyngioma that we have to look, because there are more chances of the recurrence after the conservative therapy. We have to look and we have to follow with the MRI rather than the CT scan, because CT scan have more chances of the radiation. Here, careful observation should be done in presence of the radiological progression. If symptoms is there, if vision is affected, then we have to definitely go towards the MRI and we have to do surgery. But in the absence of the symptoms, and if the radiological enlargement of the tumor is there, then we have to wait and watch, and we have to observe, and then we have to dissect. So if I summarize my slide, then the most important is post-surgical evaluation is we have to do the clinical examination at the zero baseline, 6 month, and the individualized approach. And if the growth hormone deficiency, cortisol deficiency is there, then we have to treat. If the and we have to adjust the desmopressin dose also. We have to look for the anthropometry for the growth hormone deficiency and growth hormone. If it is deviating the growth, then we have to give the growth hormone. Imagine we don't have to forget in terms of the MRI. If it is tumor size is increasing, then we have to definitely go for the radiotherapy and secondary surgery. And if the ophthalmology involvement is there, then we have to do for the MRI and the other visual examination. For the endocrine consequences, we have to look for the 0 and 6 monthly for the complication. Here, pre-T4, IGF-11 and cortisol level should be monitored. If the seizure is there, then we have to increase the dose accordingly. And stress dosing is very important here. Bone age we have to done, and we have to examine. We have to ask the history for the sleep pattern, school performance, and behavior change. If it is there, then melatonin can be the useful in this case, with the psychiatrics help for the psychological evaluation.
So moving on to the management and index case. For her craniopharyngioma, a gross total resection was done by right pterional approach, and the histopath was suggestive of histopath showed an adamantinomatous craniopharyngioma, which was in sync with our clinical diagnosis. Moving on to the anterior pituitary functions. So we know that the pre-op values had shown a subclinical hypothyroidism with normal cortisol levels. However, function done in the post-op period, about 3 days post-op, showed low FT4, low TSH, and low cortisol levels. Thus, diagnosis of MPHD was made here. So for MPHD, she was started on hydrocortisone followed by thyroxine. Looking at the posterior pituitary functions, so just immediate pre-op, her sodium potassium were in the normal range. In the 2 to 3 days post-op period, the child was found to have polyuria with a dilute urine on urine routine exam, low urine specific gravity. Thus, a temporal relation of surgery with polyuria and in presence of sodium hypernatremia, a possibility of DI was considered here in this case, and vasopressin was started, although no urine osmolality was done in this child. She was started on vasopressin, on which her sodium levels began improving. She went on to go to the hyponatremic side. Thus, vasopressin was tapered and stopped here. Cortisol and thyroid profiles were done, and they were found to be in the low range, for which hydrocortisone was started. Upon starting hydrocortisone, within 10 days of starting hydrocortisone, the child again developed polyuria, and there was unmasking of DI here in this case.
So I think this is again a message that we always say, if you start on hydrocortisone, you expect
Yes.
DI to happen. So this is what again was happening.
So this R index child had shown a triphasic response of DI, SI, DH, and DI again. So for DI, desmopressin was started here. So as we've seen, we've managed the craniopharyngioma part, we've managed the anterior and posterior pituitary deficiencies that this child had. What remains next is that we monitor her for hypothalamic complications, and although she did not have anything at the current visit, but this is definitely something that we should be monitoring her growth. Pubertal induction is something that will come up next in this curve.
I think the big thing here was that this probably came up at the right time because she did not grow to a big lesion and the site was also good. So I think this was the interesting case in which we focused a lot of discussion about pre and post-operative evaluation. Dr. Priska is asking, please explain why if morning cortisol is normal and ECG stimulation test must be done. So if your morning cortisol is very high, in the sense that if it's above a supranormal range, then you can avoid it. But before you go for surgery, maybe a ECG stimulation test will definitely be of help in that scenario. Dr. Bharani is asking, craniopharyngioma is a growth without GH state. How decide the need for GH supplements? Definitely, this is a very, very important question that Dr. Bharani has put in, that as discussed, because of the insulin resistance due to obesity, they will grow in the initial 1 or 2 years. Now, what we usually see is that after that, the growth velocity really falters down. And in that scenario, often you can do a IGF-1 level, which will be low. Now, in this scenario, you already have a multiple pituitary hormone deficiency. If the IGF-1 is low, you can diagnose growth hormone deficiency then and there. You don't need to do a growth hormone stimulation test. So it will largely be clinical. So anyway, 1 year, we don't need to treat. We will wait and watch. And usually by 2 to 3 years, we had that scenario. The boy who was coming the other time also, in which they were initially, he was tall. And then suddenly his growth became 0. And then we had to give growth hormone, pubertal induction. You can all go and have a look at our website where we have got resources like this and the courses and the mobile application. You can all go and have a look at our website, our courses which are available and the mobile application. So